update program by the KSOS Scientific Committee. And as you all know, this is the 17th module. And this time we have Dr. Harishma, resident from Government Medical College, Calicut, will be presenting a case. And Dr. Anjani K, Professor of Ophthalmology, again from Government Medical College, Calicut, will be the mentor. And in the external faculty, we have none other than Dr. Sirisha Senthil from LV Prasad Eye Hospital, Hyderabad. And welcome, ma'am. Welcome, Dr. Sirisha. On behalf of the KSOS Scientific Committee, we extend a warm welcome to this program. And this program is basically for the postgraduates. And I request all the PGs to participate in the discussion. So you can clear your doubts with the faculty here today. And this is basically a preparation for your examination also. With these few words, I hand over the program to Dr. Anjani K, Professor of Ophthalmology, Government Medical College, Calicut. Over to you, Dr. Anjani.
Hello, good evening to one and all. Let me thank Kerala Society of Ophthalmic Surgeons and Dr. Bastin for giving us this opportunity. We have Dr. Harishma, second year junior resident, for doing the case presentation. And we are fortunate to have Sirisha Senthil madam for this session. Madam is a renowned glaucoma surgeon and she head of the Department of Glaucoma Services at LV Prasad Eye Institute. Madam is interested and in managing all types of refractory glaucomas in adults and pediatric cases, and she has a keen interest in glaucoma drainage devices, and madam has many papers and very much interested in research and many awards, and she has many publications, more than 209 Best Video Awards from Glaucoma Society of India, All India Ophthalmic Society. Then she has received award from American Academy of Ophthalmology, Special Award. We are very happy to have you here, madam. Warm welcome to our Kerala. Our postgraduates will be benefited from your session today, madam.
Thank you so much. Yeah, looking forward to the sessions. Yeah.
Yeah, shall we start presentation? And Dr. Harishma, please share your screen.
Shall I start, madam?
Yeah, yes, Harishma. Yeah, your screen is visible, audible. Yeah.
Harishma, can you switch on your video also? If
Video.
Yeah. Okay, thank you.
Yeah.
Good evening, all. Thank you for giving me this opportunity.
So, Harishma, we may be interfering you in between, so you can do a very slow presentation, okay?
Okay, ma'am. So, I'm presenting the case of a 65 years old female who's a housewife from Chenavur, Kozhikode. She presented with complaints of headache, pain and redness of the left eye for 1 week duration.
Okay, Harishma, when you see such cases in emergency service, what are the diseases in your mind when you hear such a history?
When patient presents with headache, pain and redness of eye, the main differential diagnosis are acute ankylosing attack, lens-induced glaucomas, uveitis, scleritis, or keratitis. Some case of neovascular glaucoma can present as this.
Okay, continue.
History of present illness. Patient presented with headache for 1 week back, which was dull aching type, without any aggravating or relieving factors. And after 2 days, she developed pain around the left eye, which was dull aching and aggravating while looking to bright light. It was associated with sudden gross defective vision and multiple episodes of vomiting. She also gives
Harishma, you will get this aggravating while looking at bright light? Any clues?
In case of acute angle closure attack or in case of corneal edema, we can present as photophobia.
Usually for uveitis we have.
Uveitis cases also.
Okay, continue.
It was associated with sudden defective vision and multiple episodes of vomiting. She also gives history of gradually progressive painless defective vision in the past 3 to 4 years. There was no history of any colored halos, no history of glare, flashes of floaters, no history of micropsia, macropsia, metamorphopsia, and no history of any ocular trauma in the recent history. Coming to past history, she gives history of right eye cataract surgery with IOL implantation 7 years back. Surgery was uneventful and her vision improved following surgery. She is a non-case of chronic kidney disease for past 6 years. There is no history of diabetes mellitus, hypertension, coronary artery disease, cerebrovascular accident, bronchial asthma, or tuberculosis.
Okay,
There is
Ishma, how this chronic kidney disease was diagnosed?
when she went for the cataract surgery of right eye, she had a routine follow-up and her renal function test was found to be deranged. And following that, evaluation was done and she was found to have tubulointerstitial disease of the kidney. And this she was on treatment from for the past 6 years.
Okay, so along with the other eye surgery, she had this kidney disease also.
Yes, ma'am. She was first detected during the routine evaluation for that surgery.
Okay, okay, continue. Madam, if you want, you can intervene, Madam Sridhar, madam. Yes, Radishma, continue.
There was no history of any trauma or surgery in the left eye or any previous similar episodes in the left eye. Personal history, she consumes mixed diet with normal sleep and appetite and regular bowel and bladder habits. There was no addictions. Family history, no significant family history. Drug history, she gives no history of any non-drug allergy and she is on regular medication for chronic kidney disease. Coming to general examination, patient is moderately built and nourished, conscious, oriented in time, place, and person. No pallor, egress, cyanosis, clubbing, or lymphadenopathy. Bilateral pitting pedal edema was present. Pulse rate is 72 beats per minute. Regular in rhythm, normal in volume and character. Blood pressure was 140 over 90 millimeter of mercury in right upper arm in sitting position. Patient was febrile. Skin, hair, and nails were normal.
Okay, whether she had any puffiness of face or anything like that, or just pedal edema?
She did not have puffiness of face. Only pedal edema was present, ma'am.
Okay.
Systemic examination, cardiovascular system. First and second heart sounds were heard, no added sounds. Respiratory system, upper respiratory tract was normal. Trachea central and normal. Vesicular breath sounds were heard equally on both sides. Gastrointestinal system, per abdomen was soft and non-tender with no organomegaly. And central nervous system, higher mental functions were normal, no focal neurological deficit. Coming to ocular examination, eyes were orthophoric, head posture was normal, no facial asymmetry. Ocular movements, ductions and versions are full in both eyes with normal convergence, no pain on ocular movements. In right eye, the best corrected visual acuity was 6/9, and in left eye, it was perception of light with accurate projection of rays. Color vision was normal, and near vision was N6 with +3 D sphere in right eye, and both could not be assessed in left eye. Anterior segment examination of right eye was normal except for iris atrophic patch present at 9 o'clock position. No evidence of any nodules or neovascularization of iris. Pupil was 2 millimeter, round, regular, and central with both direct and consensual reflexes were brisk. In case of lens, posterior chamber intraocular lens was present, and in anterior vitreous phase, no cells were present. Anterior segment examination of left eye, lid edema was present. Circumcorneal congestion was present. In sclera, no evidence of any thinning, discoloration, or nodules. Cornea, generalized edema was present. Microcyst in epithelium present suggestive of microcystic corneal edema. Few white materials were seen adherent to the corneal endothelium. Anterior chamber, hazy view, normal depth with Van Harris grade 3. cells and fire was present. Presence of whitish shiny lens material settled in anterior chamber inferiorly. Iris normal color. NVI could not be assessed due to hazy cornea. Pupil was 4 mm in size, round, central, and direct and consensual reflexes was sluggish. Lens, white milky cortex seen, suggestive of hypermature cataract, and details of nucleus was not clear. Fundus examination of right eye. Media was clear, disc margins defined with cup disc ratio of 0.4 with healthy pink neuroretinal rim. Peripapillary area was normal. Vessels arising from the center of disc was branching dichotomously with AV ratio of 2:3. Pigmentary changes was present at macula. Periphery was within normal limits. Fundus examination of the left eye, no view was seen. Intraocular pressure by Goldman applanation tonometry in the right eye should.
Reshma,
Yes, madam.
can you go back to the image, please? Yeah, so was that no, the fundus picture. Yeah, was that an artifact, the light that you see?
Yes, ma'am, that was artifact.
Yeah, because you cannot see anything in the macula. So when you see something like this, you maybe clinically was present, but the image is showing an artifact. You should mention that.
Okay, ma'am.
Okay, and even the cup to disc ratio is not 0.4. It looks like 0.5 or 0.6. Definitely a little more than that because you can see the cupping is definitely more than that. But the rest of the things are fine. But I think these couple of findings that you say, you should make sure that whatever you're seeing, you are explaining. Yeah, please go ahead. Was there any problem in the connectivity? I'm not able to hear anything.
Madam, I have lost connection. I'm unable to. I'm in mobile phone now, madam. Please continue discussion, madam, please.
Yeah, no, I think even Reshma's connection went away. The slides have gone off.
There is no issue with this thing the live program, but I think that screen sharing is off now. Dr. Harishma, can you share the screen once more? I think Dr. Harishma can't see. Ranjini, hello? Ranjini?
Hello, ഞാൻ ഹരീഷ്മനെ ഒന്ന് വിളിച്ചു നോക്കട്ടെ. ഇവിടെ മൊത്തത്തിൽ എന്തോ ഒരു ഇഷ്യൂ വന്നിട്ടുണ്ട്.
Ranjini, I can't see Dr. Harishma in this screen. I think there is some connectivity problem with her network.
I'll tell her to join from the mobile phone.
Friend, like
Hello, Johanna.
I think there is some problem with the network with the Dr. Harishma. She's like getting it rectified. Will be ready now.
Hello, sir. I'm Harishma's friend. She'll be joining in 5 minutes. Her power just went off. That's why. That's okay. Thank you, madam. ഫോണിലെടുക്കും അപ്പൊ ഫോണിൽ പ്രസന്റേഷൻ ഉണ്ടോ ഇതെന്താ
Hello, madam and Dr. Bastian. She'll be joining soon. They are trying to sort it out. Hello, Johanna. Hello. Anaka, can you hear me?
Yes, madam, you're audible.
Yeah, okay. So you have seen this case first, no, Anaka?
Yes, madam.
Yeah. So how was the presentation she did, this patient?
This lady presented to the OPD with complaints of redness and pain. She already had a history of defective vision for many years, but since she underwent cataract surgery in the right eye around. So she, even though she had a defective vision, she had
Yeah, Harishma is back, no?
vomiting associated with the pain.
Yeah, usually this is the case happen everywhere because when one eye is operated and they get good vision, especially when they have some comorbidities, they won't turn up for the other eye surgery. So they'll land up when there is severe pain, redness, vomiting and all, then only they will land up to the hospital. So even now we are seeing many cases of hypermetro cataract, facultative glaucoma, all this in our setting. Madam,
Yeah, I think we can go ahead.
yeah.
Hello, madam.
Yeah, Anega. So What was your provisional diagnosis for this case?
Phacolytic glaucoma, madam.
Yeah, okay. So what are the other types of lens-induced glaucomas you see in your day-to-day practice?
Lens-induced glaucomas, either secondary open-angle glaucoma like phacolytic glaucoma, phacoanaphylactic glaucoma, or lens particle glaucoma, and secondary narrow-angle glaucoma like phacotopic glaucoma, or due to subluxation of lens.
Or phacomorphic, So how do you differentiate
Phacomorphic.
phacomorphic from phacolytic glaucoma?
In phacomorphic glaucoma, the anterior chamber depth will be shallow and the angles will also be closed.
Yeah, Harishma, are you ready to do the presentation?
Madam. Yes, madam.
Yeah, sir, please. Yeah, you continue. Yeah.
Yes, madam. Sorry for the inconvenience.
So Shirisha madam was telling you that in the right eye, the disc is showing some minimal cup disc ratio changes. Okay, so you must keep in mind while investigating this patient. Is that madam, Shirisha madam?
Yeah.
Yeah. So you continue your
Okay, ma'am.
presentation, Harishma.
Yes, madam. The intraocular pressure by Goldman applanation tonometry was done. In the right eye, it showed 15 millimeter of mercury, and in left eye, 44 millimeter of mercury on 4th of June at 11 a.m. And gonioscopy with Goldman two-mirror gonioscope was done. In the right eye, the scleral spur was seen in all four quadrants with hyperpigmented trabecular meshwork, suggestive of grade 3 open angle in all four quadrants according to Schaffer's grading. And gonioscopy of left eye was also done 5 days after the initial presentation, and it showed view was hazy, and it showed open angles in all four quadrants with lens materials embedded in the inferior angle. Refraction with tropicamide and phenylephrine at 2/3 meter distance. In the right eye, it gave plus 3.50 in vertical meridian and plus 2.50 in horizontal meridian. Left eye, there was no glow.
Oh, yeah.
PMT was
Harishma, so what is the relevance of doing refraction in a pseudophakic patient, considering the cataract surgery in the other eye?
the residual power of the patient will indicate the IOL power of the patient, which was either undercorrected or overcorrected.
Yeah, correct. Yeah. Okay, continue.
PMT was done, and the vision of right eye improved to 6/9 with plus 1.25 D sphere and plus 0.75 D cylinder at 180 degree, and the near vision improved to N6 with plus 3.00 D sphere. Since the posterior segment examination was not possible of the left eye, B scan was done, and it came to be normal. Coming to summary, 65 years old female who is a non-case of chronic kidney disease with history of cataract surgery in right eye, with gradually progressive painless defective vision in left eye for past 6 years, presented with sudden onset headache, pain in left eye and redness, and gross visual loss for past 1 week. Examination showed a normal right eye anterior segment with posterior chamber IOL and best corrected visual acuity of 6/9 with normal fundus, and left eye had hypermature cataract with perception of light present and accurate projection of rays. The intraocular pressure was found to be high of 44 millimeter of mercury, and gonioscopy showing open angles with lens material in the angles. Diagnosis, right eye pseudophakia and left eye hypermature cataract with secondary open angle glaucoma, probably phacolytic glaucoma with lens-induced uveitis and chronic kidney disease.
Okay, Harishma, why did you make a diagnosis like this? What are the points in favor of this hypermature cataract with phacolytic glaucoma?
The patient initially from the history itself, she's a 65 years old female with gradually progressive painless defective vision for past 6 to 7 years, suggestive of senile cataract, which matured over the years. And on examination, there was corneal edema and signs of anterior chamber reaction. Also, milky white cortex was seen, suggestive of hypermature cataract, and lens materials were seen in the anterior chamber. Everything suggesting towards faculatic glaucoma. And also in gonioscopy, there was open angles, which gives history diagnosis of secondary open angle glaucoma.
So what are the types of hypermature cataract, and how do they get complications in hypermature stage?
The types are one can be Morganglian cataract, in which the cortex liquefies and presents as milky and nucleus, which sinks in a milky bag of fluid, and the nucleus settles down. The second type is sclerotic, where the sclerosis occurs, causing the shrinkage of a lens capsule, also causing calcifications.
Harishma, what are the challenges in treating this patient? What all the challenges you will face in treating such a patient, like considering her comorbidities as well as ocular condition?
In case of faculatic glaucoma, the first step is to control the intraocular pressure. So usually hyperosmotic agents are given initially, but in this case, she was having chronic kidney disease, which is a risk factor for giving mannitol or carbonic anhydrase inhibitors. So we have done nephrology consultation for this patient for giving fitness for administering IV mannitol, but it was contraindicated. But carbonic anhydrase inhibitor, that is acetazolamide, was started for the patient with nephrology consent.
Is there any other drug that can be given, Krishna? Especially if you have to take this patient up. Yeah. Oral glycerol. So chronic kidney disease was related to diabetes?
Oral glycerol can cause ketoacidotic state in diabetic patients.
Yeah, so because the patient is a diabetic, right?
No, madam, she's not diabetic.
Not a diabetic, only chronic kidney disease.
Why did she have a chronic kidney disease?
She was diagnosed to have tubulointerstitial disease, IgG mediated tubulointerstitial disease.
Okay, so it's not related to diabetes.
No,
okay,
ma'am.
So yeah, oral glycerol is one possibility. Is there any other possibility, any other medication that one can be given to reduce the intraocular pressure other than IV mannitol and oral lastogalin and glycerol? I'm specifically talking about if you have to take this patient up for surgery. So what will be the risk if you have to take the patient up for surgery without reducing the intraocular pressure adequately?
During the surgery, in step of anterior chamber entry, there can be sudden decrease of intraocular pressure, which can cause expulsive choroidal hemorrhage, zonular dehiscence, and risk of capsule rupture.
Okay, so capsule rupture, I'm not quite sure. But yes, sudden decompression may cause the worst complication that one will fear is the suprachoroidal hemorrhage. Because elderly people and systemic instability and high IOP for a long time and sudden decompression can cause a problem. Okay. So there's another medication called dexmedetomidine, which is your anesthetist will know, they call it as Dexmed. So which can be given. There are indications and contraindications, very few contraindications that are there. But that's one more drug that can be given that can reduce the intraocular pressure by about 35% from the baseline, which is almost equivalent to the efficacy of mannitol.
Okay, madam.
Okay, so that's one drug that one needs to keep in mind, because wherever the mannitol is not, where it is contraindicated, many times this drug can help.
Okay, ma'am.
Okay.
Okay, madam. So actually, this patient was planned for monitored anesthetic care surgery, no, Harishma?
Yes, madam, monitored anesthesia.
Because usually, what is the problem with the timolol?
Timolol can cause bradycardia, which can be difficult during the surgery. So it is better to stop timolol prior to surgery.
So what are the other during anesthesia, during topical anesthesia, what extra care you should take?
It is better to give good topical anesthesia since the eye will be already inflamed and the patient will be very symptomatic. So good topical anesthesia should be given. Also, while during giving peribulbar block, the massage should be under control because the cataract is hypermature and there can be chance of dehiscence.
One step backwards, if I can ask you, when you see this patient in emergency, what medications will you start the patient on before you take it up for surgery?
Topical anti-glaucoma medications can be given. Anti-inflammatory medications are given. Cycloplegics are given.
So when you say anti-inflammatory, is it the steroid that you're talking about?
Yes, madam. Topical steroids was given.
Yeah. The topical steroids, cycloplegic,
And topical anti-glaucoma
anti-glaucoma
medication.
medication. All right. And when will you take it up for surgery?
Once the IOP is under control, we can take up for surgery. And
so let's say the IOP does not control. Okay, so I don't think we will wait for the IOP to control because unless you remove the lens, the IOP is unlikely to control. But what we can do is when the inflammation comes down a little bit, and of course we've started the patient on topical anti-glaucoma and oral anti-glaucoma medications and anti-inflammatory, the eye is less congested, less fiery. So it may be safer to operate. You can't go and operate in a hot eye, meaning like the day you see the patient, it's not a safe thing to go ahead and operate on the same day. So you'll treat them with medications and take them up for surgery at the earliest. Because many times it may not come down at all. So I would say maybe you will try and treat it for about 2 to 3 days. And third day we will re-review and see how things are. Sometimes if the patient is fortunate, we are fortunate, the pressures may come down very well. And then you can go ahead and do a safe surgery. But we need to keep in mind that not necessarily it will come down unless the lens comes out, whether it is specialized or hypertrophic. Sometimes you can still end up taking up the patient but under very high pressure. So that's why the preoperative mannitol, preoperative dexmed, or any of those things that are necessary to reduce the intraocular pressures should be taken into consideration before we take it up for surgery. And of course, a block and a very gentle massage. Intraoperatively, what precautions would you take, and which type of surgery would you do in this patient?
Controlled AC entry, controlled paracentesis is done.
Okay.
Double rhexis can be done, means first an initial capsulorhexis is done and the cortex is aspirated and later the rhexis can be enlarged to deliver the nucleus out.
Before that, would you do something else? You do a paracentesis because there's so much of milky cortex in the anterior chamber. Will you do something else?
AC wash is done to remove the materials in the anterior chamber.
Then would you stain?
Yes, trypan blue is supplied to stain the cortex because of the absence of the fundus glow, it will be difficult to see the cortex. Hence, trypan blue can stain the cortex. Also, after capsulorhexis,
Capsule.
In the cortex.
Yeah.
Cortex or capsule?
Yes, ma'am. Capsule.
Yeah.
And after the capsulorhexis, the capsular margin will also be visible if trypan blue is used while during IOL implantation.
Yes. So let me ask you this question. It's not uncommon for us to See, the minute you start the rexis, the capsule will get wrinkled, and then let's say the whole lens seems to be moving. Are there any other steps or any other modifications that you would do if capsular rexis is not possible, or when you start it, you are not able to initiate the rexis?
Capsulotomy can be done.
Okay. Any other technique? So you can also do an envelope capsulotomy. That means superiorly you can make opening in the capsule. You can finish the removal of the liquefied cortex as well as trying to deliver the nucleus and things like that with the rest of the bag intact, and then try and complete the rexus at a later time point, because usually they have very weak granules. So doing a capsulotomy sometimes may be dangerous because wherever you go and touch the capsule, the granules can give way in those areas. Other thing that can be done is you can use an MVR blade to make a nick in the capsule, and then you can use a Vanna scissors to go and cut open, so that you are not, so by doing the rexus or by trying to hold the capsule with the cystitome, you don't have much of a posterior support because there's a small nucleus which is kind of rotating, and there's no cortical support or epinuclear support because it's liquefied already. So trying to do a rexus in that eye with the help of an cystitome becomes extremely challenging, and we can compromise the already compromised granules. So one should be very careful in performing a capsulotomy. Otherwise, the whole bag can come out sometimes.
Can we use capsular tension ring?
So capsular tension ring, you tell me, can we use capsular tension ring if the rexus is not intact?
If zonules are weak.
The zonules are weak, it is different, but if the rexus is not intact, if you don't have a 360-degree circumscribed rexus with no break in the capsule margin, then you will not be able to use a CPR. So that's number one. Number two, in an eye where the zonules are already weak, you cannot go and put a CPR. If you're just trying to place the CPR, by trying to insert the CPR into the bag itself, you will compromise the zonules more. So it doesn't make sense. So no zonular, none of these CPRs and all of these should be even thought of in patients with phacolytic glaucoma.
Okay.
Okay, so what is important is that you should try and salvage the existing capsule and don't create more problem with the granules.
Okay.
So that's why I said sometimes this envelope technique can be a very useful technique. You make superior, let's say about superior, wherever it is, the pupillary margin is visible. At that area, you can make nicks and then maybe also cut it with Vannas if you want on size. Go into the bag, try to inject viscoelastic and collapse the nucleus out so that you give minimal disturbance to the granules. And once it comes out, you can actually place the lens in the bag. And once the lens is placed in the bag, and then depending upon how big a rexus you want, you can either use a forceps or you can use a scissors to cut two edges and then combine the two by completing the rexus. So that way, lens is in the bag. Inferiorly, try to make sure that the bag is intact and the lens is sitting there, because if you place the lens in a sulcus in these eyes, even though you have done a safe surgery, sulcus placement of any lens here can actually compromise the safety, and they may have a decentration or a tilt, sometimes like a sunset, or they can also have a dislocation posteriorly because the granules are so weak, and when you place an artificial lens over it, then they have a problem. So giving a support through the bag may be a better option in these eyes if we are able to salvage the bag.
Okay. Yeah, madam, excellent tips, madam. Yeah.
Yeah, so a couple of other points that I would like to add is, once we remove this and then let's say we place the lens, sometimes you see the posterior capsule is also white in color. That is because the protein has leached into the anterior vitreous as well. So in situations like that, we should not attempt to go puncture the capsule or go in with a needle and try to aspirate. Don't even touch that, because it's dispersed and it is kind of mixed with the vitreous. You will not be able to aspirate it out. Just leave it. Treat it medically post-operatively with steroids. It may take about a month's time for it to settle down. But what is also important is, because the leaky protein is still there in the eye, the tendency for the eye to have high pressures and very high inflammation in the post-operative period is something that one needs to be aware of, and we should be vigilant and try to treat them also appropriately. So these are some of the things that I think will help us while planning surgery for patients with phacolytic glaucoma.
Actually, this for the beginners, keep in mind all these complications are there. Okay, because the medical treatment and after that surgical treatment require a very good expertise to manage to do a uneventful surgery for a hypermetric cataract. So all the steps are difficult. Capsulotomy is difficult, nucleus delivery is difficult. Even IOL positioning and dialing may also cause zonular dehiscence. All those problems will be there in hypermetroid, this small diameter cataract. So how did you manage this after this, Harishma?
And after giving acetazolamide, the patient's IOP was under control, and it came down to 22. And then lens extraction and IOL implantation was done for the patient under monitored anesthesia control.
Oh, so this case is successfully managed and IOL is implanted. Very good. And patient is also happy with your treatment.
Yeah, wonderful case and very well presented, Harishma.
Thank you, ma'am.
Actually, madam, this nucleus delivery also will be very difficult, no? Because nucleus will be like pearl-like, without any optical adhesions. It will rotate in the capsule itself. So to deliver out from the bag also very difficult, yeah.
That's true. That's true. Yeah, very nice. Dr. Ranjini, you are very good. Asking them
Thank
very
you.
relevant questions.
Yeah, thank you, madam. Yeah.
Yeah, so it's a big opportunity for them to learn.
Yeah, madam. Yeah. So thank you so much, madam, for joining us today. So all of you PGs, please read and have adequate experience in medical treatment, surgical treatment, and you should have adequate knowledge about what are the complications, anticipated complications, so that you can be well prepared and go ahead with these sort of cases.
All right, good.
Dr. Bastian has left. Yeah, he said he has some meetings. Madam, do you give systemic steroids for all these cases or only topical steroids? Madam?
Topical steroids.
Topical steroids also. Okay.
But maybe instead of just giving it 6, 4, 3, 2, 1, depending on how the inflammation is in the post-operative period, we may want to continue it a little longer. But some eyes, they do very well. If there is not much protein leak into the posterior segment, they clear very fast. But I think post-operatively will manage, but no systemic steroids.
Yeah. So if there is any delay, so much of delay in doing cataract surgery, sometimes patient will have glaucomatous optic nerve damage. But usually we don't see that type. Otherwise, some ischemic optic nerve damage may be there because of the very high IOP and all. But these are the
so
cases.
that is a very important point. I think post-operatively, to evaluate the fundus is important, and sometimes you don't see the pallor and things like that immediately. Maybe a month later, 2 months later, when you see them, it's a good idea to maybe do a baseline visual field test if you feel that the disc is not looking healthy. If there's some pallor and things like that, it's always good to evaluate and then try to have a baseline test done, so that in the future, you don't know whether the new problem has happened or whether the glaucoma is worsening. Very rarely, in my experience, I've seen maybe 1 or 2 patients with phacolytic glaucoma who continue to have elevated IOP even beyond the first few months. and they required continued use of topical anti-glaucoma medication. So it's rare, but yes, it's like you said, if it is delayed or if somebody is predisposed otherwise with a primary glaucoma, and on top of it, if they have developed a lens-induced glaucoma, then those patients are more prone.
Madam, like that in this facultative glaucoma, sometimes we doubt whether perception of light is there or not. But when we proceed with surgery and all, later patient recover vision and like that also we
Correct.
Yeah.
Yeah, that's very common. So projection of rays is something that we need to worry about. So usually PL will be positive, but sometimes if they have very, very dense cortex, both in the anterior chamber leaf as well as posterior segment, it is so dense that it is not allowing the light to pass through. So they may not be able to accurately tell us, but if it is of a recent onset and you know that there is no neovascularization of the iris, there is no other features of chronicity, then we should be able to go ahead. Of course, we will do a B scan to rule out any other RD or any other problem that would actually contribute to this. And then under a guided prognosis, we should go ahead and do it. So usually perception of light is present, but then use a very bright light. They may see it dimly. We have to try and explain it well. But projection of rays inaccurate in two quadrants or so, I don't think you should worry much. Okay, so I think we can go ahead and do a surgery, and most often we will be able to manage it, and they should be able to get reasonable vision.
Yeah. Dr. Bastin, so even in each and every district in our state, we have very good cataract surgeons and cataract surgery is being done, but still we see cases with facultative glaucoma in now also. Most of them are with the other comorbidities. So they have other physical challenges or other comorbidities, then multiple comorbidities. And recently I had a patient who is very young, 30 years, but he had hemophilia and none of the surgeons were daring to touch him. And he has to be on this factor 8 this thing supplements during surgery, and so those patients surgery will be delayed and finally they will end up in some centers like us because of the financial issue, and then mentally challenged many are there, psychiatric patients. So bilateral mature or hypermature cataract we see routinely.
Yeah, madam. Good evening, all. I am Dr. Ajesh, Scientific Committee member, KSOS. On behalf of, we had a very good discussion on facultative glaucoma. Thank you, madam. On behalf of KSOS Scientific Committee, I extend my heartfelt thankful to Dr. Sirisha Sindil, madam. Thank you, ma'am. And I also thank my own professor, Dr. Anjali, madam. Thank you, ma'am. And thank you, Dr. Harishma, for presenting today's topic. And I thank all the participants for making today's discussion live. Thank you all.
Thank you so much, and thanks for the opportunity.
Yeah, thank you, madam. Bye.
Bye-bye.
Nicely